Hey everyone, and welcome to the Balanced Bodies Blueprint. I am your host, Vinny Russo.
And I'm your co-host, Dr. Eryn Stansfield.
And we're shifting gears from all the conventional fitness narrative you hear on most fitness podcasts, as our main emphasis lies in preventative healthcare, adopting a holistic approach to nutrition, and challenging the traditional views on various fitness topics.
Our mission with this podcast is to provide you with the information you need to achieve optimal health.
And on today's podcast, we're discussing the labs that you should actually pay attention to and continuously monitor throughout your life. So I will be guiding this discussion, but Dr. Eryn is going to be the one that's going to be explaining everything, what the labs are and why you should pay attention to them, so on and so forth. So without further ado, let's dive into this topic, which I think is going to be a pretty big hit because of how relevant blood work and lab work is today. Say hi to Moose, our dog. But before we get into the discussion, is there anything you want to preference this discussion with?
Yeah, so I should emphasize that labs aren't typically quote unquote routine. So not every time you go to your doctor do you need labs, especially if you're young and healthy. Usually they're done as part of an annual physical, but all labs are geared by clinicians based on your age and clinical presentation. So if you're having a specific problem, different labs will be ordered and different labs will be recommended throughout your lifetime based on, again, your age group and what you're at risk for. So these by no means are standard every time labs that you go see your physician. These are in general what physicians would get as part of a normal physical at a certain age.
Okay. So now when we go over these, are they going to be like in order of importance or are they just going to be random ordering?
No, so they're not in order of importance. They're just, like I said, there are labs that are done usually as part of a physical or the ones that we get as far as baseline goes.
All right, cool. So what's the name of the first lab you would want to go over?
All right. So the first one that I think is important is CMP. And you can go ahead and ask away what you would like to know about the CMP.
Well, first and foremost, can you just explain what CMP stands for and what it actually includes?
Yeah, so it stands for Complete Metabolic Panel, which sounds fancier than what it is. Basically, it includes a list of electrolytes, and typically along those electrolytes are sodium, potassium, and along with those are your BUN and creatinine. So those are two kidney function markers that are important. So not only are we looking at electrolytes, but we're looking at kidney function with this particular test, especially if you're getting it as a routine thing. So as part of a physical, for example.
Now I get the electrolytes, but what's the significance of BUN and creatinine?
All right, so let's talk about what BUN stands for, or BUN. It's blood urea nitrogen. So the kidneys filter out urea. And so this is a marker of kidney or renal function. Sometimes in a normal person, and mostly I'm going to address, a normal physiological person that goes and gets these labs done. We're not going to go into too many scenarios where there's a pathology or a clinical disease, essentially. So if you're going to get these labs drawn, typically they're going to be normal. And by normal, I mean within the range of the lab parameters. And so your blood urea nitrogen occasionally will rise with dehydration. So sometimes people that are fasting that get this lab done while they're fasting will notice that their BUN might be slightly above normal. And that's likely due to the fact that they haven't been drinking too much water because they were fasted for the test. Occasionally, protein intake can affect it too. If you have a high protein diet, sometimes your BUN might be a little bit higher or in the high normal range. Abnormal BUN levels can be associated with medical conditions. And like I said, we're not going to cover tons of pathology, but anything obviously anything related to kidney function, but also other things like congestive heart failure, urinary tract obstruction, GI bleeding, and sometimes severe burns. Again, the normal population isn't going to see too many changes. It's a very non-specific finding. A lot of these tests are going to be very non-specific, right? We look at the entire clinical picture as clinicians. And then the other one that we get is creatinine. Creatinine, again, is another function of kidney function. And we do look at that. Bumps in that, again, can indicate dehydration typically if it's low, like a low normal bump. So anything above the 1.0 mark, occasionally we'll think, oh, that might be because the patient's dehydrated. And then obviously if at the higher it gets, then we start worrying about your kidney function. And medications over the counter, for example, that are filtered through the kidney are some NSAIDs or or anti-inflammatory medications. So sometimes if you're on a lot of those, that can affect these numbers as well.
What about so I heard before that if you work out a lot or if you're extremely sore from working out, like I had a really hard workout, it might increase these numbers. Is that true?
Yeah, that is true. And there are pathological protein breakdown, like rhabdomyolysis,
Yep.
that would definitely be into the pathology range. Like some people experience this with a very hard, long workout. There's different thresholds for different people, but we see this a lot in people who maybe do like those very long distance running. And sometimes they'll get muscle breakdown, and obviously that's going to affect kidney function. And so you'll see bumps in those numbers because of that. Again, those would be a pathology or a clinical syndrome.
So how does BUN and creatinine, how do these levels help in assessing kidney function, and why is it important to monitor them regularly?
Well, I don't think it's important to monitor them regularly necessarily. So I don't want to ever say you have to get these labs all the
Mhm.
time because, again, like I said, the caveat is that your clinician will decide when it is important. These are typically done as part of a physical just to make sure that you're in the normal range. Um, you know, with with concerns for kidney function, that's when it becomes a little bit more critical. Like we want to know what your BUN, creatinine. These are the very entry level labs that we would get to indicate there's a problem, and they would, your creatinine would be bumped above 1 typically, not just like low, like not 1.1 or 1.2, but we're talking about higher ranges. 3, 4, that's going to indicate that there's an actual renal problem, or kidney problem. And so, it kind of depends on the clinical presentation. But again, if we're doing this as part of a routine physical, we're just looking to make sure that those numbers are your electrolytes and your kidney function are going to be in the range of the population that is measured, which is in the normal range.
Awesome. All right. And just to let our audience know, if you don't know, renal and kidney are synonymous. Okay. So
Yes.
whenever you hear that term renal, we're referring to the kidneys. So let's go on to the second one. What's your second test that you would look for?
So I like LFTs, and LFTs basically stand for liver function tests.
Mhm.
Um, we can talk about what liver enzymes are typically included in the panel. And you can get a complete panel or an abbreviated panel.
There's a few of them. So just
Yeah.
use their abbreviations because those names are kind of hard to pronounce anyway.
So usually what you'll see, like if you get liver function tests, they're usually not labeled that if you look at your printout. But what you'll see on your, usually it's right after your metabolic panel or shortly thereafter, it'll say ALT, AST. Those are different enzymes found in the liver. And those are the normal ones that are typically done. And then you can get an extended liver panel that will include things like ALK phos, and then your total bilirubin. and albumin, total protein, and sometimes a prothrombin time. So, so let's run through. So the most important ones, I think, for just general basic liver function, you know, again, this is a healthy person who likely doesn't have any major medical issues going for their routine physical. You'll usually see an ALT and AST within range. Occasionally, you'll see an elevation in these two enzymes, and that can likely either be due to sometimes alcohol. Some people are just more prone to not process alcohol as well. And it's not necessarily indicating any alcohol problem, but sometimes you'll get a slight bump because your liver just doesn't like that. And then obviously if you have issues with alcohol, then you'll see bumps in those. And then another reason for a slight bump might be again, Tylenol. So acetaminophen is processed through the liver. And occasionally, if you're taking a lot of Tylenol at the time, you'll get a small bump in typically ALT. But so those you'll see mild elevations. If you get the other lab parameters in your full liver panel, like the ALK phos. It's an enzyme found in various tissues, liver, bones, kidneys, intestines, but an elevated level, can indicate either a liver problem or bone disease, occasionally bile duct obstruction, but that will be accompanied by other elevations as well. Another one that's obtained as a full liver panel is a total bilirubin. So the liver does break down old red blood cells, and that this is a clinical or a lab marker for that. But elevations in total bilirubin could again indicate many issues. Again, non-specific. It can indicate liver disease, a bile duct obstruction, or excessive breakdown of red blood cells. And then another one that's obtained is albumin. Again, albumin is a protein that's produced by the liver, and it helps maintain blood volume. So low levels of albumin are seen with liver disease or any medical condition that might affect protein production. Another one is total protein. Abnormal total protein can indicate, again, liver disease, kidney disease, or malnutrition, or some other conditions as well. So again, these are very non-specific things that kind of guide clinicians, especially if you have a medical or list of symptoms that they're looking for to rule out. So they kind of lead the clinician down different pathways. And then the last one that's usually part of a full liver panel is a prothrombin time. And this becomes very important especially if you're on something like a blood thinner, Coumadin, that sort of thing. And people that are on these medications are very familiar with prothrombin time and INRs, which are the International Normalized Ratio. And they have to be in a certain parameter to make sure that you're getting the adequate amount of medication. And obviously, liver disease can affect blood clotting factors. And so sometimes you can get a prolonged prothrombin time and elevated INR.
So let's just say, as an example, someone's worried about liver disease or just something wrong with their liver. Maybe they're on gear and they're afraid, or maybe they take a lot of medications and they're afraid of it, going through the liver. What are the first things that you're looking for that show red flags, like, oh, you might have something going on with the liver here?
So typically, like I said, just on a normal lab panel, like let's say somebody comes in for a routine physical, but they don't give me any information and they're worried about it, but they're not telling me. So like I said, the ALT, AST are going to be the first markers that are usually part of the routine lab panels that we get that are going to look somewhat elevated. And then once those look elevated, again, the clinical picture becomes very important, because then I would query the patient, say, hey, are you, have you been drinking a lot lately, or, are you taking a lot of Tylenol? What kind of medication are you on? So that kind of guides the conversation. And then if they start saying, yes, and maybe it comes out that they're on they're taking other medications or other drugs that may be affecting their hepatic system, then that's when we start saying, all right, let's order some more specific tests to check liver function. And then, of course, there's imaging you can do. So, one of the biggest problems in the United States is cirrhosis, and alcoholic cirrhosis is a very big problem. And it's besides hepatitis, right? So there are scans now that actually can check the amount of fibrosis in the liver without necessarily getting a biopsy. So not only is there's lab indicators, but then there's also imaging that's going to probably be indicated depending on how severe the liver disease is. But it's kind of the initial tests that are abnormal that you start putting together the pieces, of the puzzle and asking the patient what their personal history is, what their medication use is to put that together.
Yeah. And once again, for our listeners, she used the term hepatic. Hepatic refers to the liver.
Yes.
So just real quick too, because I remember you telling me when people go into the doctor's office and they're like, well, how often do you drink per week? And they're like, I don't know, 4. And isn't there like a multiplier that you always multiply because no one ever tells the truth?
Yeah, so it's very unfortunate, but in medical school, we are taught, especially when it comes to drinking, that most patients aren't going to be forthcoming about how much alcohol consumption
Mhm.
they have typically. We usually don't ask about it that much. We'll put it in the history, but especially if there's an abnormal liver finding, then we start. Then we start querying the patient. And if the patient says, I only have 2 drinks a week, then you know, that's not necessarily forthcoming if their liver enzymes are elevated and there's no other explanation, right?
Mhm.
So it's typically on higher on the priority list as far as like why their liver enzymes might be elevated. But yeah, so a lot of physicians will multiply by 2 or double whatever they're telling you, because like I said, it's very difficult for some people to be forthcoming. And to be honest, like some people don't really know how much alcohol they consume. Um, it becomes, it kind of sneaks up on you. So some people are, kind of are very aware of where they are with their alcohol consumption, and other people are,
Once they get
are
going, they don't stop.
yeah, and
Yeah.
some of it might be denial as well.
Yeah.
So we do have screening tests, as far as the like brief questionnaires. The one I learned in medical school is the CAGE questionnaire. Do you want to cut down? Do you feel guilty? Um,
So this could be a whole episode in itself.
yeah.
We don't have to
So
go into the
so
question.
there's, but yeah, so
Yeah, people pause and taking the test themselves, seeing if they're an alcoholic.
yes. And there's more elaborate questionnaires out there too, but that's kind of, when we start seeing physiologic abnormalities, we start asking why, right?
Mhm.
Like we want to find out why. And so alcohol is one of the basic ones that we kind of question people
Yeah.
about.
I just thought it was funny because like when you first told me that, I was like, yeah, usually I'll do like 1 time per week.
Yeah.
This is like, well, I was in college, I was saying that. I was like, this is a bunch of bullshit.
Yeah.
But let's go on to the third lab that you would want people to pay attention to.
So a CBC is often ordered. And a CBC basically stands for a complete blood count. And what are we looking at, especially in females, but in males too? We're looking to make sure, your blood counts look okay. Occasionally, we're a little bit more prone to do them in females because of iron deficiency anemia. Females do menstruate and sometimes develop iron deficiency anemia because of that. But in males, again, they can be anemic as well. Alcoholics can be anemic. But also we're looking at your white blood cell count, your red blood cell count, and hemoglobin, hematocrit. If you're on testosterone, your hematocrit tends to increase. And so we are looking at those parameters. But I think the most common especially younger population that's healthy. Occasionally, what we're looking for are any signs of anemia besides, an elevated white blood cell count, if you're ill or have an infection or a virus or something like that.
Well, two questions here. So, number one, um, how would you start to like when you're looking at the labs and the results? What's going to basically push you towards saying, hey, this person might actually be anemic?
So your hematocrit and hemoglobin, those are going to be, and for females and males, they're different. And also it kind of depends like how severe it is, but the other parameters I think are important. So we look at those first, right? If those are low, then we start saying, well, is it iron deficiency anemia? What kind of anemia is it? Iron deficiency anemia just happens to be common. Um, more than some of the other anemias, but we look at your MCV count. So that is your mean corpuscular volume. Basically, if you have smaller cells, so your MCV is smaller, it's microcytic. So that's going to be an indicator of something that might be more along the lines of iron deficiency. Your MCH number, your mean corpuscular hemoglobin, again, this would be low. And then your MCHC, which is your mean corpuscular hemoglobin concentration. Again, that's going to be on the low side.
Mhm.
Now, one thing that would be on the high side or higher than normal in iron deficiency anemia is your red cell, the width of your red cell, so your RDW, sometimes that will be increased. And the reason for that is because your body, usually if you're anemic, your body wants to make up for it. So it's trying to make more red blood cells. And the half-life or the life of red blood cells is roughly 3 months. So you're looking at a 3-month period usually. But the immature cells are a little bit bigger. And so your body's trying to make more red blood cells. And so a lot of those cells are still immature. And so that one would be increased in iron deficiency anemia. But it's important. There's many causes of anemia. I'm just talking about one of them, just very general. But that's typically, your complete blood count just can give us information about any infectious process because of white blood cell count, and then obviously any anemia or reasons to have an elevated hematocrit, like drugs,
Yeah.
testosterone, for example.
Well, that leads into the second question, which was when we're looking at hematocrit, and if your hematocrit's high, it's just your viscosity of the blood is high, right? There's more blood cells in your blood. So one thing that I know is a good tool to use if your hematocrit is pretty high would be to go donate blood. What numbers are you looking for to actually be like, okay, maybe I need to go donate some blood?
Well, that's a good question. So in the literature, usually, usually 58, between 58 and 60, you want to be concerned, but it kind of depends on the clinical picture again, like what's the reason? I think you're asking this question because a lot of people are on testosterone. So you're
Hmm.
likely asking like, at what cutoff level do you go get your blood drawn? And it depends on the clinician as well. Some people will say, any number above 56.
Hmm.
Um, but I've seen clinicians go down to, 58 to 60 before they recommend that. But really, I think that if your hematocrit is consistently in those ranges, then you got to ask yourself, am I on the right dose of testosterone? And
Yeah.
so again, the clinical picture becomes important. Like how much testosterone are you on and what are your test levels? So that's why it becomes important. It's not just one number, one parameter, and that's it. Like you go to the, to get your blood drawn. It's more of like what's going on, what's the entire picture.
Yeah. Yeah. It's kind of like having two clients that might be on testosterone, and one is, you know, asymptomatic, just has a high number, and the other one's showing like a really red face and has the
Yeah.
same number, but that's a little bit higher. You're like, all right, maybe that guy got to go give blood then compared to the other guy. So it's
Yeah.
individual as well.
Yeah, well, and why do we worry about this? Because of increased viscosity. We worry about clots, like blood clots and stuff like that. It's just harder to move more blood cells through your vascular system when your blood is thicker. And at the end of the day, we worry about Virchow's triad, high viscosity, immobility. Those sorts of things can be a setup for blood clot.
Yeah. All right. So let's go on to number 4. What is the 4th lab that you're like, hey, we should pay attention to?
So the one I see a lot, and this one's not routinely, I really want to emphasize it's not routinely ordered. Okay. When you go get your physical done, they don't automatically check your thyroid. But if you do sometimes mention some clinical symptoms, one very vague and one that's mentioned is fatigue, for example, a clinician might say, all right, let's make sure your thyroid function is okay. So it is common, but not necessarily routine. So it just depends on the provider really and what the patient presents with. And typically a lot of providers will just get a TSH if they're not functional providers.
And
A
what is
TS
TSH?
So thyroid stimulating hormone. So TSH is produced by the pituitary gland. It basically stimulates the thyroid to produce the thyroid hormones, so T3 and T4. And an elevated TSH can indicate an underactive thyroid, so hypothyroidism. And then while a low TSH level may indicate an overactive thyroid, so hyperthyroidism.
It makes a lot of sense because if it's stimulating the hormone, if it's high, it's trying to stimulate more and more hormone.
You got it.
Because it's low. And if that number is low, just for everyone that's listening, it's basically saying like the body doesn't need it because you have enough of the thyroid hormone in your body.
Yes. And then, so that one is usually, most clinicians can figure out whether you're hyperthyroid based on just a TSH number. Okay. So all of these providers are getting these elaborate thyroid panels, not necessarily indicated.
Wait, so we don't need reverse T3? Is that what you're saying?
Yes, not unless you're in the ICU and critically ill. The other one that a clinician might get is your thyroxine. T4 is the main hormone produced by the thyroid gland, and it exists in 2 forms. So free T4 and total T4. Free T4 represents the fraction of T4 that's not bound to proteins and is available for use. And then total T4 just includes free and bound to proteins. So they occasionally might get a T4 level, but you can tell a lot just from a TSH level. And then T3 is not routinely done by most clinicians unless you're a functional provider. That's where I've seen it. But it is the active form of thyroid hormone. Why don't we get it? You can listen to our whole thyroid episode, but basically it's very difficult to actually pin down a level for T3 because it is produced by different organs in the body and the half-life isn't that great. And so it's not a good indication of a level of T3 is not actually a good indication of how much T3 is actually used in your body, if that makes sense. Another one, though, I will mention, is especially if there's concerns with your thyroid function tests, often obtained as a thyroid antibody test or TPO antibody. These are measuring basically, as it directly says, antibodies against your thyroid. So elevated levels of these antibodies can indicate an autoimmune disease. So we're looking at Hashimoto's or Graves' disease here. And, once you're diagnosed with one autoimmune disease, they tend to run together. And so sometimes there'll be panels to figure out if you have other autoimmune diseases or if it's just your thyroid that they're worried about.
So you might not want to give this number, but because I know even with our clients, when initially we get lab work and maybe like there's a range where it shows it's on the lower side and you're normally like, nah, that's normal. Like what number are you looking for to where, because I would say, low thyroid would probably be the biggest concern of most of the population. So what number or numbers would you be looking for to say this person might have, a condition with low thyroid hormone?
Honestly, it would be the lab parameter, and I'm not going to give you that number off the top of my head. I'd have to look at the lab. But I will say this about that. So a lot of functional providers will say, well, it's in the low normal range, or it's still within range, right, of the lab parameter, but they'll start diagnosing people before it even hits that range. And I think that's not it's not good clinical work. It's basically saying that a patient who is normal has a medical problem,
Yeah.
and you got to understand that these thyroid cutoff numbers have been studied in large populations, and although there's quote unquote subclinical um, uh, thyroid issues out there that some of these providers like to peddle, uh, these people often have thyroid hormones and TSHs within the normal ranges.
Yeah. Yeah. And it would just like if you just take a step back and you actually look at, what these providers are providing, or even a coach that says, hey, it's kind of low. Let's put you on T3. You go on a thyroid hormone, you're gonna lose some weight from it, right? So that makes the patient happy to always say, oh, this provider treated me good. This is what I wanted. I wanted to lose some weight. I was stuck and I couldn't, and I thought it was because of my thyroid, and it was because he gave me thyroid hormone or she gave me thyroid hormone, and now I'm losing weight. When in reality, that's actually going to hurt you in the long run. Um, yeah, so I see that. I have seen it a lot. And now with more of these functional coaches coming out and functional practitioners, it's even more so in terms of relevancy.
Yeah.
Let's go into another one. So do you got another one for us?
Yeah, so a lipid panel, right? So lipid panels are usually obtained in your 20s, but it can be obtained in your teenage years, depending on your family history. So what's a lipid panel? It's a fancy name for a cholesterol panel, basically. So what's measured typically in a, day-to-day one is a total cholesterol, LDL, HDL, and triglycerides. LDL, we like to think of as your bad cholesterol, HDL, high densities. HDL is usually good cholesterol, and then triglycerides are the fat content in the blood. And so typically, as far as what are we measuring here? So we have pretty good indicators from studies, observational studies, that an increase in LDL does increase your risk for heart disease. HDL, a high number, can sometimes be a better number protective, but the data there is less. That there's pretty good data for high LDL numbers corresponding to atherosclerosis or risk for atherosclerosis. And then again, triglycerides can be a risk factor for heart disease as well. Total cholesterol I take with a grain of salt because you are measuring all the LDL, HDL, so the good and bad cholesterol. And occasionally we'll look at ratios. But why is this important? So hyperlipidemia, or again, an increase in LDL seems to increase plaque formation, and numerous factors can contribute to the development of atherosclerosis. So again, I spoke of Virchow's triad. This is kind of a triad as well, where you have endothelial damage, so that's damage to the blood vessel, and then you'll have a perfect storm of somebody with hyperlipidemia, and then they get inflammatory factors, and maybe they have increased blood pressure, so hypertension, and maybe they smoke on top of that. So this is all a bad thing for atherosclerosis plaque formation. But basically, that is what predisposes you to having heart disease, are these plaques. And basically, as these plaques grow, they narrow the artery. And if you reach a certain point of narrowing, you're prone to get a heart attack or a myocardial infarction. So it's basically a pathologic process, but this is one of the first indicators of that process beginning. And so that's why we emphasize like please lower or please watch your diet. Obviously, family history, genetics play into that. I don't just want to say it's a person's diet because there are many, many factors that play into elevated LDL numbers. But the one that we can change is diet and watching what we eat and making sure that LDL number does stay lower.
Yeah, and just to touch on what you said about the total cholesterol, if you have high HDL, like your total cholesterol might be high, right?
Yeah.
But the HDL is quote unquote the good cholesterol.
Yeah.
So you're going to have a higher. So what I think is really important is really going to be the ratio of LDL to HDL, correct?
Yeah, the ratio becomes important, and there's different ratios that are calculated, and there's even like risk calculators for your chances of having a cardiovascular event, whether that be stroke or MI. For example, the Framingham score. So a lot of the clinical parameters will look at ratios, or they'll even go into more invasive, not invasive, more further testing, like they'll test for other like apoproteins. So there are other tests that you can get. Again, these are just your basic lab tests that you might get and what red flags you should look for. So if you have a high LDL number, I think, besides like calculating a ratio and stuff like that, that's really the number you want to focus on
Mhm.
trying to lower.
Now, let's say we do have elevated LDLs, elevated triglycerides. Um, what lifestyle changes would you recommend, or any treatments would you recommend to kind of mitigate the damage that could occur in the future?
So most clinicians, depending on the elevation, if it's a mild elevation, they'll start with diet and exercise, basically. So the
So
most
so
common,
hire us.
yeah, the most common, like again, a lot of Western physicians are not trained in diet, but we have seen very good data with a Mediterranean-like diet for lowering LDL numbers. Um, and so that's typically along the lines of what a physician would recommend, right? But they kind of just give that to the person and then give them a few months to try to lower it themselves. And then if that doesn't work, they start looking at medications. So,
Yeah.
statins and stuff like that, where they'll start saying, all right, well, you weren't able to lower on your own. And, again, family history plays into that. Genetics, there is a genetic component. So some people do their best on their diet and they have a beautiful diet, but then um, their genetics just aren't there. And so they do have to have some kind of medication intervention. And that's not necessarily bad. But if you can change it with your diet, then you can avoid medication sometimes.
Yeah, and what I normally like to say is like when in doubt, like Mediterranean it out. Like plain and
Yeah.
simple. Just, I mean, there's a lot of research behind it that supports it. So I would say, do that and just make sure you're moving a lot. Like just walk a lot. Try to get, the markers 10,000 steps. But if you're on average getting, 7,000 steps per day, bump it up an extra thousand. Try to get eight. When you get used to that, bump it up another thousand. If you're normally getting over 10,000, then keep that up and keep moving around. Um,
I will
but
say that most of the data indicates decreased cardiovascular risk at 8,000 steps, not
mhm,
10.
yeah,
And
well, it
they've done
goes,
lots of studies on that.
well, it was like there was a significance from like 2,000 to 8,000. Then there was a little bit of significance from over 8,000 to 16. Then
Right.
anything over 16, we didn't see any real change at all. So like that sweet spot is just increasing by a little bit, right? But let's go on to the last one that we're going to talk about. This is number 6, I believe. So what is the last lab that you want to discuss that we should be paying attention to?
All right, so I like the hemoglobin A1C. I like it. So it basically looks at the glycosylation on your red blood cells, so the amount of glucose on red blood cells. I mentioned earlier that red blood cells are typically made every 3 months on average. And so the hemoglobin A1C is a 3-month reflection of how much sugar is on that red blood cell. And that gives us a good clinical indicator of whether your blood sugar levels are in a normal range or you're a pre-diabetic or a diabetic. And I think it's better than a fasting glucose, because a fasting glucose, you have to be fasted. It's one measure in time.
Mhm.
Lots of factors can affect it depending on how long you're fasting, what your last meal was, that sort of thing. And then the other one is an oral glucose tolerance test, which is a pain. It takes a long time to do, and it's kind of, people don't like it. So I think it's just a better measure overall to tell us whether you're pre-diabetic or diabetic. And
Is that because it's the 3 month mark? Like it's a 3 month?
yeah, and
Okay.
it's a three, and most lab tests are just one instance in time. There are very few lab tests that give us like a 3-month view of what's been going on, and this is one of them. So, and I've seen this number change, by the way, from me being in medical school to me treating, or me being a practicing physician, the parameters for pre-diabetic and diabetic have changed. In other words, they've lowered the hemoglobin A1C number. And the reason for this is one, I think that we've had a huge obesity problem, and the thought process behind that is to, if we can diagnose people sooner, catch the pre-diabetic stage sooner, then we can treat these people and maybe avoid some of the cardiovascular disease or microvascular complications that happen along with that diabetes. It used to be a higher cutoff value, versus now that
So
cutoff value has lowered.
what are the values?
So, back when I was in school, a hemoglobin A1C was your diabetic, and now they've lowered that to 6. And if you're getting in the high 5s, you start being in the pre-diabetic range, essentially. So,
What was
so
it while
that's
you were in school? Do you remember?
7.
It was 7. Wow.
Yeah, yeah. So you
Okay.
weren't diabetic until had a hemoglobin A1C of 7. And I remember before that, when I was an undergrad, it was like 8.
Oh, wow.
So yeah,
Yeah.
so it's
I
been
think it's
lowered and lowered.
Yeah, I think that's smart because, like you said, I mean, if you catch it early, you could prevent it, right? You could
Yeah.
prevent all that future stuff that you got to deal with afterwards. So let's talk about that future stuff. What are the implications of having a higher HbA1c?
So hemoglobin A1C, obviously, if it's higher, you're going to be diabetic or pre-diabetic. And there's multiple, basically, sugar on any blood cell starts to damage the blood cells. You get microvascular disease on the very, small level. And then on a bigger level, you start having other issues. You're at risk for cardiovascular disease, for kidney disease. But a lot of diabetics will notice the microvascular disease first, like as far as symptoms go. Let's say they haven't had a blood test. A lot of patients will present with numbness and tingling in their hands or feet, and that's
Mhm.
microvascular. That starts as microvascular disease because the sugar starts to, because there's not appropriate insulin. Release, it starts to damage some of the nerve cells and blood cells in the hands and feet. And, you've heard of diabetic ulcers in the feet. So some people get so much nerve damage that they can't even feel, if they stub their toe or they step on something and they hurt themselves, and then they get wound infection. So these are very basic, kind of the first signs. But obviously those can progress and cause major problems. And, I think the biggest one is the cardiovascular disease as far as like major complications.
And just what would be like your go-to for driving that number down?
Again, diet's going to be big. So lifestyle changes, big lifestyle changes. again, there are genetic components to, especially type 2 diabetes. But diet's going to become increasingly important. Glucose management, and these are the people that do have to check their blood glucose levels on a very often basis. I see a lot of the glucose monitors now, and I think the FDA just recently came out and approved them for use in like normal people. I think it's interesting, right? But these are the people I actually need to check their blood glucose often.
Yeah. Not a big fan of the continuous glucose monitors, just like in the average person who doesn't need it. Like,
no.
I mean,
And it's what you do with the information, like what kind of data, like, why measure something in a normal, healthy organ system when there's no pathology?
Yeah.
What are you going to do with that data?
Yeah, very well said. Very well said. Dr. Eryn, thank you so much for really diving deep into those 6 main labs that people should pay attention to. And our next episode, we're going to do a part 2. And we're going to have Dr. Eryn dive into some of these labs that you should avoid at all costs. And it might not even be specific labs you get in your blood work. It might be a type of lab that we see getting passed around a lot nowadays. I won't say what it is, but stay tuned for our part 2 coming next week. So on behalf of Balanced Bodies, we just want to say thank you for joining us on this episode of the Balanced Bodies Blueprint.
We are committed to bringing valuable content. And if you enjoyed today's episode, we'd greatly appreciate it if you can take a moment and like it and leave a 5-star review.
On Apple, just go to the show, scroll down to the bottom and rate it there. If you're on Spotify, go to the show's page, click the 3 dots, and you can rate it there as well.
And if you believe in the power of knowledge, share this episode on your social media to try and get the information out there to as many people as possible.
And as you navigate your own path towards better health, remember that Balanced Bodies is forever in your corner. See you all next week.
The podcast content may include discussions of medical topics and health-related information. However, the information provided should not be considered exhaustive or complete, and it should not be relied upon as a substitute for professional medical advice or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding a medical condition or treatment.